We'll get started since we're trying to keep this within everyone's little morning. Not everyone gets coffee breaks anymore, but we'll assume that you do. So good morning, everyone. My name is Dee Dee Montgomery, and on behalf of the Oregon Institute of Occupational Health Sciences and the Oregon Healthy Workforce Center, we're again pleased to bring you to I guess it's our third COVID conversation. Again, intended to be kind of short soundbite conversations to get us thinking about topics and sharing ideas. We would encourage those of you listening in to use the chat function to share questions. The format is basically 20 minutes of discussion. I'm going to introduce Kate Wood in just a second today, who is our moderator. And she will introduce our speakers today. And then in about 20 minutes, we'll go ahead and start having our speakers, our guests today, answer your questions, who we, again, very much appreciate their being here. This will be recorded, and as in the past, you will get an email if you registered in terms of when the recording is available, and you're welcome to share it. We put it on our Oregon Healthy Workforce Center webpage or YouTube page, along with the others. And we are now, Nicole's going to put a link in the chat if she hasn't already, where we are going to, now that we're starting to catch up, and we're going to start letting you know who's ahead of in the lineup. We're continuing to do the second and fourth Tuesday mornings of the month. We're attempting to alternate between occupational health nursing side and environmental health and safety side, and it's not always going to be perfect in that rotation, but that's who we're targeting. So we do have confirmation for our next two, and we'll get more details to you on that. Our next one in 2 weeks will be June Vining, who provides mental health assistance to public service staff, public safety staff at the City of Portland. And there's going to be some conversations about mental health in the time of COVID. And then the following one is Cliff Butler, who's an environmental health and safety manager at Sherwin-Williams. And so without further ado, I welcome you all, and I'm going to go ahead and turn it over to Kate Wood. Thank you, Kate.
Thanks, Dee Dee, and good morning to everybody. I'm Kate Wood. I'm retired, but I am a volunteer board member of the Oregon State Association of Occupational Health Nurses. And I really appreciate the support that we've gotten from the Healthy Work Center and OHSU to provide these coffee breaks that hopefully you're able to take. This morning, I have two nurses who are part of the employee health COVID triage team at the Portland VA Hospital, Sophie Butigan and Emily Cooper. Welcome. Can you hear me?
Yes.
Yeah, oh, good.
Hi.
Hi, good morning. You know, a lot of folks that are listening today are from the occupational health and safety side. They're not medically trained, and they don't work in the healthcare industry. But, you know, healthcare facilities, hospitals, medical centers, very complex organizations with a lot of the sort of back office operation, facilities, landscaping, maintenance, housekeeping, laboratories, a wide range. And so I think that the work that you two have been doing is going to be very relevant to a wide range of industries that we work with. And a lot of folks have said, you know, since COVID started, their job duties have changed and their relationships have changed. Now, a year ago, both of you were direct care, bedside, doing what my daddy used to call real nursing, because he could not understand what I was doing. And now you've jumped in both feet to the world of occupational and employee health. Tell us a little bit about what that means to you and the relationships that you've had that have supported that transition. Sophie, you want to start with you?
Sure. Yeah. So actually a year ago, I was just about at my due date in my pregnancy. So my son was born on the 18th of March. So this was all kind of starting right when I was extremely pregnant. And so I was on maternity leave for the beginning of COVID. You know, the week that I started maternity leave was when we got our first COVID positive patient in the hospital, and I had been on light duty for a couple of weeks before that, but that was kind of my that was on my way out. It was like, oh, okay, I guess this is happening.
So
And
that's quite a
so
transition, yeah.
yeah, and it was I ended up actually just going on maternity leave a couple days early because it was kind of like I think this is a sign that maybe I'm just gonna maybe I'm done now.
So that you were
And
able to
so
get back.
yeah,
Yeah.
so I was on maternity leave for about 4 months, and then when I came back and my baby was still very tiny, and so I took a temporary reassignment away from patient care, and then I transitioned to this assignment as well in about December, and
So you
it's
probably have a very sensitive sense for any of the employees who are pregnant or new
yeah, absolutely,
parents.
yeah,
Yeah. Emily,
and
how
it's
about you?
yeah.
Emily.
Yeah, it's interesting. I was thinking just as Sophie was saying that, it's almost a year to the day that we had our first COVID positive patient in the hospital.
Yeah.
And I was not on maternity leave through that. So, I was very much present and, hands-on with those COVID patients through that whole process and all of the transitions. And I've been in employee health now since October. I think a big part of it for me was definitely a needed transition. It was a lot very quickly, being a real nurse, as you said, with those COVID patients and all of those transitions. And it was equal parts personal and professional. I think, some personal protection and a personal, kind of step back from that pace for myself.
Mhm.
And also, having an interest in, how does the back office work to this? How does that look like? How are those going? How is the evolution occurred, and being really hands-on and learning a lot more about that side of it.
So there was an employee health structure in place. So you're finding yourself working with people who have worked in the hospital for a while to keep the operations going. What type of relationships have you been able to develop there with safety, environmental health? Are those people that you ever encountered before? And how do you see them working with employee health?
Yeah, Emily and I were both charge nurses in our inpatient ward. We were both on the same ward, and so I think I definitely worked with employee health prior to this, and we both had been, we have certain programs in employee health, like we have what we call our flu champion program, where we have kind of nurses all over the hospital who have been deputized by employee health to give flu shots. And so we had both been involved in that program. So we had met and worked with employee health, the department before this, never this closely, but it was kind of we had gotten glimpses of it before. And they've been very welcoming and supportive, and our COVID team has been kind of separate from the employee health group, but we're kind of, as time has gone on, we've kind of become more integrated, and we're all kind of taking on a little bit more regular employee health duties.
Now, you had mentioned that early on, having enough staff available to come in and keep operations going was a real challenge. How did it affect the hospital's ability to continue operations?
Do you want to talk? I guess, Emily, you were around during that.
Yeah, there was a lot of transition very quickly. Initially, we were kind of cohorting all of the COVID patients on one floor, on our home floor for a while. Then they were moved, and staff was moved to kind of to staff on another floor. And so at one point, our staff was split, actually. Most of us were working on the third floor together, but a portion of us went to the sixth floor to help out there. And just physically, a lot of transition with, you know, a group of people that had been working very closely together, most of us for a long while. You know, at one point, we'll kind of touch on this, but there was the first outbreak of COVID amongst employees and staff members in the hospital. That happened within, you know, kind of those three groups of our home floor working with COVID patients, those that were deployed to the third floor to work down there, and then also our combined 8th and 6th floor that were working together. And I wasn't here for that portion. There was a portion there that I was part of an outbreak that happened, and I did test COVID positive myself. I feel comfortable sharing that. And I think that was a big part of also the reason to come to employee health and see the other side of it is I saw the employee health side of it as, you know, kind of the patient and working as a positive employee and getting through that process. So yeah, that's a little bit of an overview.
Sorry,
Yeah,
you can probably hear my recycling is being picked up in the background, so I apologize to everybody. Can't schedule this. Did the on the back office side, on the facility side, housekeeping, food service, were those services affected, and how did employee health step in to be able to help keep them going, not only with the patient staffing, but all of the operations that you rely on to be able to care for the patients?
Yeah, they definitely changed. I mean, I'm sure everyone remembers, especially early on, but even continuing for months and months, there were changes, you know, sometimes every day, sometimes multiple times a day of our policies and our protocols and procedures and stuff. And so they definitely implemented some pretty big changes. We stopped floating nurses to other floors for a while. We did close 2 of our units for a number of weeks, I believe. You know, we did deep cleaning, we did various things, and then we stopped floating nurses for several months. I think until about October, we started floating nurses again. And as a result, we had to, you know, cap down our patient load because we couldn't, you know, if one floor did not have enough nurses for patients, then we just could not admit. And so we definitely, our operations were pretty significantly affected in that way. Similarly, we did have, you know, the food service workers and the housekeepers do go to multiple floors, but they did, you know, managers and the bed flow people made a big effort to try and keep people in one area as much as possible.
Definitely
for
initially,
as long as we could.
Initially too, like those types of workers, like housekeepers particularly, or really anyone that wasn't, you know, had an absolute need to be there, they were really kept out of patient care areas as much as possible, and a lot of those responsibilities were put on the nursing staff. And, you know, it became, you know, nursing staff is now going outside the ward to like pick up patient meal trays and, you know, reducing the number of people that are having contact with the patients in that way. You know, we took on a larger role of, you know, taking out daily trash in our patients' rooms, you know, trying to protect those groups of people as much as we could.
So you had mentioned, Emily, that you yourself was exposed and tested positive. And I know one of the duties that you've had has been exposure assessments. And you have you called it a risk stratification algorithm that you use to help workers in all parts of the hospital understand what the severity of their exposure is, so that they could either keep working or where they would be able to work. Can you talk a little bit about that tool?
Yeah, absolutely. I think Sophie might be able to bring it up to have a good visual there.
So it is, can you see that?
And
there.
thank you.
Yep.
So it is, our risk stratification table is pretty complicated because it does involve, you know, healthcare or medical care, and so you know, we when we assess people for exposure risk, we're we're assessing people both who are exposed at work, providing care, and then also people who are exposed in the community. So, their child had a positive, someone tested positive in their childcare, or they had a family member that they spend time with, or someone who lives in their household tests positive. And so this, this table, and this is this is just the first part of the table, and then this is the second part. We over time, we've had times when we've had more complicated tables with different categories, but right now all we have is highest risk and not highest risk.
Okay.
And so we've kind of divided it into there, and that was in working with our infection prevention and control team, infectious disease, and various kind of expert people in our facility. We work together to determine this stuff. But so when someone calls in, we look at this. But if it's a community exposure, if you're talking about people who, it sounds like a lot of people who are calling in maybe aren't necessarily working in the healthcare setting. In the community, we mostly stick to the 15-minute, 6 feet, and whether they're wearing a mask rule, because that kind of boils it down. If you're not doing, medical care.
So who is the person that does the evaluation? Is it employee health? Do you rely on supervisors? Who's applying this?
Yeah, as far as contact tracing go, I mean, it is a group effort, but really the bulk of the work is done by supervisors. We have a great Excel spreadsheet that it is designed to be very simple and answer, those main questions of what type of interaction was this exposed person having with a positive person? Were they, within 6 feet of that person? What was the time frame? And then what, personal protective equipment were they wearing during that interaction? And then it's formulated so that spreadsheet that the supervisors use to interview their employees will make a calculation, if certain criteria are met. It'll let you know right there that person is going to be considered highest risk. It does take, at times a fair amount of auditing on employee health part once we receive that information back, to kind of go back and review and, look at, is this really making sense? And kind of using some clinical judgment there for sure. And that's been one of probably our biggest challenges, is number one, that education piece for supervisors who, a lot of them don't have any healthcare background necessarily. And, referring to all sources and kind of walking them through the steps of what it looks like and what it looks like to be done thoroughly and correctly, and why that's so important to be done. So yeah, like I said, collaborative effort, but really we're overall very grateful that the supervisors are generally able to do a really good job to help us out with that kind of minutia there.
And so the employees self-report to their supervisor, the supervisor applies the algorithm, and then it's passed on to employee health for an oversight. What happens to the employee that comes up highest risk?
The idea would be that the supervisor would let them know, right then and there on their interview, that they would be considered highest risk. That doesn't always happen, but either way, the primary response is to quickly let that employee know that they're considered highest risk, and explain to them why that is, and then quickly get them sent home if they're at work, and them through our quarantine and return to work process.
It kind of depends. Sometimes the notification can kind of vary depending on, was it an employee that tested positive that this person was exposed to? Was it a patient? Is it someone, are they working on the inpatient side? If it's an employee, was it a community test or was it a test that we performed as employee health? We do order tests and do them in-house, but then sometimes people get tested by their primary care or whatever, and so they have to let us know. So it kind of depends. We still have some stragglers sometimes. You know, we will still find out about, oh, someone will say, oh, I tested positive, 2 months ago, and we have never heard of this person. And so, kind of tracking down, okay, well, what was what happened there to make it so that we didn't know that they were testing positive, and we can't really do contact tracing at that point. But there's definitely a lot of reinforcing the message to the supervisors and the facility on a whole is that when in doubt, call us and we can help you kind of triage that situation.
And I've noticed we've gone over our time already, but before we turn it open to the chat, when an employee has tested positive or you've had them in quarantine, do you test them before they're allowed back to work? And you had mentioned that while you would clear them perhaps of having a negative test, the release to work comes from the primary care doctor because sometimes symptoms can linger for an employee and they're not able to come back. Can you talk a little bit about that, Emily?
Yeah, so if it was an exposure, for example, a exposure, we do now test those employees before they return to work. We've moved to, for most of our locations, a 10-day quarantine post highest risk exposure with a negative test no sooner than day 7. So with a negative test and they have no symptoms, they could return to work after a 10-day quarantine. For employees that have tested positive, we don't do a test-based return strategy for them. They don't need to test again before they come back to work. If a positive employee never developed symptoms, for example, they would do their 10-day quarantine through their specified period of infectivity and then could be released back to work. Not every employee is needing a release from their primary care provider. It's really case-by-case basis and how their symptoms have developed, how they're feeling. Certainly if they're not feeling well after 10 days and don't feel like they can, perform their job duties at that point, we refer them to their primary care for continued care.
Yeah, that's definitely been an ongoing kind of discussion about, we based on all the criteria that we see from CDC and WHO and all those places, the evidence shows that about a 10-day period past the onset of symptoms or the positive test date is the period of infectivity where we're most concerned. As I'm sure a lot of the symptoms can linger for weeks or months even, but we don't think that people are contagious at that point past that 10-day period. And so that's why we would release them for monitoring at 10 days, but just like any illness, if people aren't well enough to be at work, then they have to kind of communicate that with their supervisor, and their supervisor may or may not want them to get a doctor's note if they have to stay out longer. It kind of depends on what their specific department situation is. And that's when we would involve their PCP. And we do, we make it clear when we speak to people that, employee health, we do testing and we provide return to work guidance, but we don't actually provide, any medical care or treatment. And so that is something that they need to go through their PCP for. And so a lot of them are, in contact with them as well already.
Well, and I kind of knew that there was going to be a lot more for you to talk about than the 20 minutes would allow, but we're at 9:25 now. So we've got, I think we have Dee Dee or Nicole. Do we have questions in the chat that we would like to have Emily and Sophie address?
We do. We have some really great questions. Emily and Sophie, thank you so much for giving us this insight into how the Portland VA has handled this. I know I've learned something already today. A question here from Megan. Were either of you involved in the effort to vaccinate employees? And what, if so, do you have any lessons learned or tips for those of us that might be considering on-site vaccination for employees?
Yeah,
We
Emily, you want to take this?
Yeah, we had kind of peripheral involvement really in the first push to vaccinate employees, and it was really driven by a combination of other departments. Certainly, employee health has taken on a lot of the documentation role in that, and that's I think probably our biggest challenge is kind of collaborating between different departments and people to make sure that we're consistent with documentation. We are using a new program to document our COVID vaccination, which comes with challenges. We have documentation in several different areas that needs to be done in different ways. So that's really been the biggest challenge in that regard. But as far as physically staffing vaccination clinics, it has not been primarily employee health. Nurses have been drawn from various other parts of the care system to be that kind of hands-on effort.
Yeah, we did when we first started vaccinating. There were clinics that were run basically by the hospital, so it wasn't part of employee health, although we were involved. And it was similar to our flu clinics where they had a bunch of nurses from all over the hospital, and we did this just giant push to get as many people vaccinated as possible, staff members. And then once we had gotten the bulk of those people, in about mid-February, we transitioned to doing kind of smaller clinics run by employee health just a couple days a week. And we've prioritized new employees during that now. So, and only employees who are patient facing at this time, because, we had this huge supply of vaccines. And then after that push, it kind of dwindled a little bit. Now we're starting to get a bigger supply again. So maybe we'll be able to open up our criteria a little bit more. But that was, it's definitely the transition to having employee health running the clinics when they've been run by another group has been a little bit of a challenge. And I've actually spent the last couple of weeks trying to figure out our numbers. I see Marilyn asked what our vaccination rates are among staff, and that is kind of a question that I've been working on for the last couple of weeks, to try and determine what is our actual denominator of staff. And then we also vaccinated a fair amount of other federal employees, Veterans Benefit Administration, National Cemetery employees, and various other people in the regional network of VA and various people. And so trying to kind of, as we've discovered in the effort to vaccinate as many people as possible, there was some record keeping that didn't necessarily get kept. And so trying to pull out how many of these are actually our employees. The official number right now is about 74% of employees are vaccinated by us. We are, some people have been vaccinated outside of the VA, and so we're gathering that information. People have to send us their cards, and then we have to update our system to kind of to update our numbers. So that's just based on people that we personally vaccinated is about 74%.
Wow.
And it's about 8,300 doses, I believe, have been given by 2 employees, which is about 4,000 people. Some people don't finish their second dose for, because they've had an allergic reaction or various reasons. So it's not 1-to-1 exactly, or 2-to-1 exactly, but approximately a little more than 4,000 people have been vaccinated by our facility. And in terms of how many veterans have been vaccinated, we don't have those numbers right now. That's run through primary care, and so I would love to know those numbers as well, but we don't have those at this time.
How interesting. Well, make sure you're doing your hand exercises for all of that repetitive motion with the flu shot or the and are you offering electronic vaccination records to employees, or is it the card? Or
we can on request. We do give people the card when we do it, but we are also, we are bracing for the point when everyone loses their cards, because we know that will happen. So we do have an electronic record, but as Emily said, it's had some quirks. And so we're finding a few people where it wasn't recorded, or just something funky happened with it. And so we're telling people to please hold on to their cards as best they can, and trying to identify those people that It may not have been recorded properly just due to technology. But yeah, we do have, we chart in our occupational health record system as we're giving them. But the paper is always the backup. But I think we had I think I know of 3 people who immediately afterwards said, "Oh my gosh, I forgot to take the card out of my pants and I washed it, and can I get a new card?" So there's definitely some challenges.
Records management, of course, naturally is hard with so much data.
Yeah.
So that's a really great consideration for all of us. You know, I really thank you for answering Marilyn's question about the vaccination rates. And I wanted to find another one. Now, Marilyn also remembers that in the early days, that some medical providers were having a little bit of a challenge distinguishing between isolation and quarantine. Did you have the similar experience in your workplace?
I think, I don't know, do you feel like, Emily? I don't know. I feel like we definitely use a lot of different terminology. We just say stay home. You know, we definitely, when we tell someone to stay home, we tell them what, you know, in addition to staying home from work, we want you to stay away from other people. We want you to wear a mask around anyone. You know, we want you to keep your distance within your household if you're able to. You know, I think that is true, that there is kind of a question about what is quarantine, what is isolation, what is any of these things. And so we try to be more specific about the actual activities that people should be doing rather than using that kind of terminology.
That's an incredible feat to be able to communicate individually with each participant. And it really, I think, speaks to your dedication to the humans that you're serving. I mean, that's just remarkable and wonderful. I can't imagine the project management involved with all of this. And documentation, I just want to make sure that I'm grabbing all of the questions here. Tracking vaccination, I see. And in healthcare, when you are tracking vaccinations, you spoke a little bit about how you would have some employees that might go through PCP and some people who might go through employee health. You know, what kinds of things are you noticing that's different in healthcare environment regarding vaccinations and that success versus other kinds of employers?
I guess I haven't worked in a non-healthcare setting in a long time, so I'm not totally sure how to speak to non-healthcare settings. I know, you know, I mean, it is interesting that, you know, we are at 74% vaccinated. You know, it seems like, in some ways, it seems like it should be higher, and then in some ways, you know, we understand people being cautious. We're kind of right now working on a questionnaire to go out to people who have chosen not to be vaccinated at this time to try and assess, you know, where is their hesitancy? Is it related to, you know, concerns about the newness of the vaccine? Is it because they have an underlying condition that, you know, if they have an allergy, or do they have a religious objection? Is there some, you know, trying to capture what we could do to increase those numbers? Because right now we don't know, you know, we've just been offering it to people. It's not required currently, although we're kind of anticipating that at a certain point it might become required, similar to the flu shot, which we also, you know, didn't require up until a couple of years ago, or this year, maybe 2 years ago. We started actually making it mandatory unless you have a medical or religious exemption. And so, you know, that is kind of a question of what is underlying that choice for people.
Well, I think it's a question we all share, and won't it be interesting in the coming months for all of us to go back and evaluate some of that? I really appreciate that you are doing that kind of evaluative work and just digging a little bit deeper into understanding your population. I think that's all the questions we have for today. I thank you both so much, Sophie and Emily. This has been a really productive and very interesting discussion.
And thank you both. Welcome to the world of occupational and employee health. I hope maybe the 2 of you will see a future in it.
Yeah.
And we certainly want to thank you and all of the staff at the Portland VA for the service that they provide to our veterans.
Thank you.
I'm Kate Wood, retired and board member of the Oregon State Association of Occupational Health nurses. I want to thank you all for attending today and looking forward to your feedback and letting us know topics of interest, questions that you have that we might be able to find somebody, or if you're willing to come and speak with us, we're very happy to talk with you. And thanks so much, Nicole, for handling, and Dee Dee, you're back. Thanks very much. Do you want to wrap it up?
No, that's great, Kate. I think we're not going to do surveys anymore. We got some of their interesting information, but what we're going to encourage you when you get your email is to just respond back to us if you have a suggestion for a topic or speaker. I think that'll be a little more direct at this point. But thank you, Kate, and thanks everybody.
Thanks so much, Emily. So